Does Singapore hold the keys to a united Ireland? Singapore is one of the greatest success stories of the 20th century. Gaining independence from the UK in 1963, the country transformed itself from a small trading outpost to an economic powerhouse. Today, this country of 6 million people boasts total reserves of over 1.5 trillion US dollars, an astonishing feat for a country smaller than Ireland's smallest county. Singapore's journey from third world to first rested on the shoulders of an unbending visionary leader, Lee Kuan Yew, and his government's sound economic policies. One such policy is the subject of this video, due to its potential to address Ireland's biggest problems, and the closer one examines this policy, the more obvious its all-Ireland implications become. If a referendum is called, voters won't base their decision purely on economics. Identity matters in Northern Ireland, and a walk around parts of Belfast reveals the strong British connection that exists, whether that's to Charles III or William III, the Dutchman fondly known as King Billy. Before we get to Singapore, we need to talk about Europe, where resources in every country are allocated by a combination of markets and government intervention. In sectors like rail and energy, a strong role for the state is often preferred, due to a political preference for public ownership of key infrastructure. In other sectors, such as food, markets do all the heavy lifting, with supermarkets and smaller stores competing on price and quality. These are generally for-profit businesses, though in the UK, for example, the cooperative chain holds about a 6% market share, while in Switzerland, the two biggest co-ops have around a 70% market share. Affordability and inequality are addressed on the buyer side through subsidies in the form of social welfare payments, and in some countries, through food stamps. On the seller side, besides regulating stores, governments may subsidise food banks and other charities. So in food, we have market-based supply, while governments confine themselves to regulation and subsidy. This brings us to healthcare, where the implications for a united Ireland begin. Writing in the Irish Times, Professors Brendan O'Leary and John Garry tell us that some 50% of Northerners are more likely to vote for unity if a united Ireland adopted the type of health system used in the UK, and only 3% will be less likely to do so, with the resulting net score of plus 47. Europe is divided into two types of systems: universal health insurance, or UHI, and tax-funded systems. In the Netherlands, which has a UHI system, the hospitals are 90% non-profits, 10% private, and there are no government-run hospitals, with government confining itself to regulation and subsidy all round of providers, insurers and consumers, with the poorest having their insurance premiums paid in full. The structure of the Swiss system is essentially the same, but the mix on the provider side is different, with a larger role for local governments and for-profits in running hospitals. Swiss health insurers are required by law to be non-profits, at least for essential cover. As for the tax-funded systems, the largest and most famous of which is Britain's National Health Service, the government is overwhelmingly dominant. It runs 85 to 90% of the hospitals, it pays for people's GP visits, and it is the national insurer, although around 12% of the population holds private insurance. If we imagine a healthcare system as an orchestra, the Dutch government is the conductor, gently guiding everybody along, while the British government is simultaneously the conductor, sitting at the piano and playing the trombone. The NHS has been likened to the UK's true religion, the one institution that the whole country can get behind, whether it's spontaneous rounds of applause during COVID or forming the centrepiece of the Olympics opening ceremony. The NHS was based on the egalitarian ideals of reformer William Beveridge. But according to American healthcare economist Dr. John C. Goodman, Britain's National Health Service hasn't lived up to the rhetoric.
Now here's what's interesting. We go about 20, 30 years into the system, and the British study themselves more than any other country. I don't know if you're aware of this. So we have a commission that has as its objective to study how well we're doing at making healthcare equal for everyone. And it was called the Black Commission. And they came out with a report and they said, well, we're sorry to report that, in fact, it doesn't look like we made any progress at all. That there seems to be just as much inequality in the health system today as there was back before the NHS was started. So then we go another 20 years and have another government commission and says, it came out and said, oh, we're very sorry to report that since the last commission report, things seem to have gotten worse. And I think we're waiting now for a third commission.
In Northern Ireland, Whatever its confessional differences, when it comes to the NHS, everyone is a believer. Down south, there's a hybrid system. The Health Service Executive functions essentially like the NHS. The government runs most hospitals, but also funds some voluntary hospitals. And GP visits are only free for the less well-off. Roughly 47% of people are covered by private health insurance, with the government-owned VHI Healthcare holding about 50% market share. In 2010, plans were announced to sell VHI, but the 2011 coalition government reversed the decision, instead proposing to move Ireland towards universal health insurance, similar to the Dutch model, retaining VHI Healthcare as a public option. In 2015, a report was published by the government think tank the ESRI, stating that UHI could increase costs by up to 10.7%, leading the new health minister to cool on the idea. Since then, the cross-party reform programme Sláintecare has sought to move Ireland closer to the NHS as a free, tax-funded system. But this is where things get interesting. Comparing healthcare systems is fraught with difficulty, as a population's health is more dependent on lifestyle, diet, prosperity and age profile than it is on the healthcare system. The OECD's Healthcare at a Glance is a useful guide, and a reasonable starting point is deaths that could have been avoided with medical intervention. Here the picture's pretty mixed. Ranking countries in order, 3 UHI systems come out on top, though some Nordic countries and Italy perform well among tax-funded systems. As for access, the best performing 5 are all UHI systems, with Norway and Spain the best performing among tax-funded systems. Ireland finishes in the middle of the pack, and by far the largest reason for lack of access is waiting lists. UK data is not included, but we know that waiting lists in England stand at over 7.5 million people, while there are reports that half of Northern Irish patients wait over a year for treatment. As for satisfaction, again UHI systems dominate, with Ireland and the UK in the middle. Comparing healthcare spending is also tricky, as prices in healthcare are largely absent, but the US is generally thought to spend the most per person in the OECD, followed by Switzerland and a host of European countries, which apart from Norway are mostly UHI systems. So there's merit to the claim that UHI systems can increase costs. Ireland and the UK are in the middle of the pack on spending, but comparing cash amounts doesn't factor in the higher wages in very wealthy countries like Switzerland and Norway. So when viewed as a share of GDP, the UK's spending is the same as Switzerland, casting the NHS in a less favourable light. Ireland's figure here is meaningless, as its GDP is skewed by the activity of multinationals. Perhaps a fair way to summarise the difference between UHI and tax-funded systems is that the gap is not that large for life-saving treatment, although the best systems are still UHI. But for waiting times and overall patient satisfaction, UHI systems clearly perform better. Given these findings, the wisdom of Ireland moving closer to the UK's system needs to be seriously questioned, not least because if Ireland had the NHS's performance right now, there would be 2,500 more avoidable deaths each year. Of course, there are better performing tax-funded systems than the NHS, but if performance is the goal, UHI has to be considered. Ireland is moving closer to the NHS each year, with free care gradually expanded and spending is rising. The health budget in 2016 stood at €14.1 billion. Next year it will reach €25.8 billion. Even allowing for population growth, inflation and COVID, this is a steep rise.
As a result of the bureaucratic institutional control of our healthcare system, none of us ever sees a real price for anything. And by a real price, I mean a price that reflects the marginal cost the way it does in every other market. By everybody, I mean no doctor, no patient, no employer, no employee. None of us is looking at real prices. So when we have artificial prices, we enter the market with perverse incentives. And when we act on those perverse incentives, we make things bad for the system as a whole. So as a patient, if I'm not paying for my care, I have incentive to overuse the system. See the doctor more often than I would. Take pills I really don't need. Go get an MRI scan, even though the benefit is much smaller than the cost of the scan. Over on the doctor's side, their incentive is to overprovide because in this country, they're paid fee for service. The more things they do, the more they get paid. The insurance companies who are paying the doctors have an incentive to underprovide. So they question what the doctor's going to do, deny authorization. So everybody's facing perverse incentives, and we don't have the equilibrating mechanism that goes on in a normal market, which makes our self-interest consistent.
One way to control spending is to impose cost sharing on the patient, which along with prices allows healthcare to function like a real market. But the idea of making patients pay for care is resisted by many, although this must be weighed against making them wait for care. The RAND health insurance experiment from 1974 to 1982 remains the largest health policy study in US history, and it found that modest copays did lead to a reduction in healthcare usage, but the majority of the reduction was in low-value or discretionary care. For essential, life-saving treatments, people still sought care. Switzerland bears this out. It has the highest copays in Europe, but the best outcomes. And through generous subsidies, it is one of the most egalitarian systems.
Can the market really work in healthcare? And we hear that a lot. And my quick answer is that the market is the only thing that works in healthcare. Look at any place in healthcare where the third-party payers are not. There's no Blue Cross, no Medicare, no employer. That's a market that probably works pretty well. So cosmetic surgery is one example. There's no Blue Cross, there's no Medicare. We're paying with our own money. And what happens? We get package prices, we have price competition, quality competition. And the real cost of cosmetic surgery has gone down over the last 2 decades, even as the number of procedures has soared. All kinds of technological improvement of the kind that we're told raises costs everywhere else in the healthcare system. So the market works really, really well. We have lots of examples of it. When you have patients spending their own money, it's not working at all when you have third-party payers paying the providers, and the patient is merely an excuse for money to change hands.
But how can you ensure equality between rich and poor if people pay out of pocket? This brings us to Singapore. In 1955, the British colonial government established Singapore's Central Provident Fund, or CPF, a compulsory retirement scheme. And following independence, Singapore began expanding the CPF for other uses.
That CPF money is then divided into 3 sub-accounts. There is a portion that goes into MediSave, there's a portion that goes into what's called the special account, and there's a portion that goes into the ordinary account. So the MediSave account can be used for healthcare costs. The special account you can't touch until you turn 55 at all. The ordinary account, you're allowed to touch some of that for housing costs.
Permitted spending items from the ordinary accounts include buying a property, education and investments, and deposits to the CPF are tax-free. The UK and Ireland have private pensions similar to Singapore's special accounts, and the UK has its post-tax individual savings accounts to encourage wealth creation. Ireland has no such scheme. On a related note, if you would like to earn returns of up to 9% per year, Property Bridges allows you to lend directly to experienced Irish home builders through their investment platform, which is regulated by the Central Bank of Ireland, and investments are secured against the property. Those living overseas may also invest. So to learn more, visit propertybridges.com. Our sincere thanks to them for sponsoring this episode, and to our Patreon subscribers, who chat with us on Discord and help keep the channel going. Back to Singapore. Its population is a little larger than Ireland's, while it has slightly fewer hospital beds, and its share of public hospitals is slightly lower. Public hospitals in Singapore are required to break even, and they have high levels of autonomy, including on hiring. On the consumer side, the Singaporean government pays money into the savings accounts of the least well-off, and any unused funds over somebody's lifespan can be passed on to one's children tax-free, so people have an incentive not to waste it. When the government runs unexpected surpluses, it often parachutes money into people's accounts, which are received with gratitude by the voters. As it happens, John C. Goodman is generally regarded as the father of healthcare savings accounts.
Well, I've been to Singapore, and I believe they began their MediSave account about the same year that Richard Ron and I wrote about health savings accounts in the Wall Street Journal, but I can't say they got the idea from me. But I have been there, and I have studied it a bit and talked to people there, and it's very impressive. And there's a huge amount of spending in Singapore is coming out of pocket. I think it's 30 or 40%, very, very, very high. And it's not a completely free market. The government does regulate prices for doctors, and there are various other regulations. But people have a lot of control over their own healthcare spending. And the way I look at Singapore, it's really remarkable beyond the healthcare system. It's as though Singapore looked at Europe and everything Europe did wrong, all the needs that Europe tries to meet with a welfare state. Singapore is meeting with savings. So they have a private social security system, private retirement, and there are more millionaires per capita in Singapore than almost any other country in the world. I think they're number 2. So it's been not only great for the economy because you have all this savings, which is translated into investment, which fuels economic growth, but you have people meeting their own needs, making a lot of their own decisions, and getting wealthy.
To understand why healthcare savings accounts work so well, let's imagine somebody thinking of buying any good or service. They will have 2 considerations in mind: their ability to pay and their willingness to pay. A rich person doesn't have to worry about ability to pay, only whether they're willing to pay, whereas a poor person worries about both. Singapore ensures that everybody has the ability to pay, while retaining the need for them to consider value for money, which helps the whole system. But what the NHS does by making everything free, and what Ireland is now trying to do, is remove both considerations, which leads to overconsumption, setting the whole system on an unsustainable path.
In many parts of the world, healthcare is free at the point of consumption. I believe that's the case in the UK. I think that's the case in most of Europe. That's also the case in many countries in Southeast Asia. They've unfortunately gone down a bit of a dangerous road. So because of that, once you get people into the habit of healthcare being free at the point of consumption, it's very, very hard to unwind it.
In democracy, there's a tremendous pressure to not save. It's really, really tempting for politicians to take money that people think they're saving and spend it in order to get votes.
While the Dutch have a UHI system, their politicians have not been able to resist the temptation of making GP visits free, and insurance premiums are slowly rising, with not one party brave enough, or silly enough, to propose GP charges.
Well, what's happening in Europe is it's all pay as you go. So and it is in the United States and in Ireland. So all the payroll taxes that people are paying are immediately spent. Nothing's being saved. What happens in Singapore is the payroll tax goes into an account that you own. And so it's not that people are habitually psychologically inclined to save. It's the government makes them save. The government makes them save more than they otherwise would have. And the interesting result is by the time they reach the retirement age, they're a millionaire or close to it.
And in Singapore, they don't stop at healthcare savings. They force hospitals and other providers to publish their prices, so that a patient, in consultation with their doctor, can compare providers and judge for themselves who is delivering the best value. This shopping around is happening most of all for elective procedures, such as knee replacement, hip replacement, or cataract surgery, which is where Ireland and Britain struggle the most. The results in Singapore are staggering. Singapore is not a member of the OECD, so it doesn't appear in their rankings, but its outcomes are among the best in the world, comparable with Switzerland. Yet it spends less than $4,000 per head on healthcare, less than half of Switzerland, and well below European and wealthy East Asian countries. But what can Ireland realistically hope to learn from Singapore?
The situation that we have in Singapore is fairly unique. Right? It's a small country. We are still relatively young as a nation. People have only experienced this particular party in power. I myself have only ever had one political party in power for my entire life. And for me, for my generation, for my parents' generation, we've seen that party perform well. They've generally delivered on their promises. I mean, Singapore has one of the highest GDP per capita in the world. There are things that you're unhappy about, but I travel out of Singapore. I tell my friends in Singapore, look, whatever you're complaining about here does not compare to what you see out there. Right? So I think there's a lot of performance legitimacy which allows the government to do these things here. The other thing I think is that the government has been very consistent in their approach to fiscal sustainability. So in the realm of healthcare, for instance, there has been constant emphasis on the need for skin in the game on the part of the patient in order to avoid excessive utilization and all the other problems that standard health economics will tell you happens. Everybody understands that skin in the game is important, co-pays are important, they're part of the general philosophy with which we approach healthcare.
Consistency was a large reason for making Sláintecare a cross-party initiative, rather than changing course after each election, but the course is highly questionable. In Britain, the Labour Party may succeed in getting the NHS back on track, but this is a high difficulty manoeuvre, requiring high levels of execution. There's also the question of what politicians can be expected to achieve. In Ireland, North and South, politicians are elected through a ruthless ground game, as summed up by North Down election candidate Tim Collins.
They're interested in local politics, they're not interested in cutting VAT, they're not interested in international affairs, they're interested in potholes and hedges.
Down south, The Taoiseach has made no secret of the fact that he's gunning for the seat of the Health Minister Stephen Donnelly, who's rumoured to have neglected Wicklow's potholes and hedges in favour of the health service. An Irish election amounts to selecting the pilots of the state for the next 5 years, yet voters expect the pilots to serve them tea and sandwiches throughout the flight. Given the impossible demands we place on politicians, doesn't it make sense to use markets to make their lives easier? Imagine the nightmare task facing a British health minister. 1.5 million NHS staff, thousands of hospitals, 7.5 million people on the waiting list, and overworked doctors and nurses threatening to go on strike. Now imagine a hypothetical British Minister of Food, an even more fundamental human right than healthcare, yet apart from cutting the odd ribbon at Asda and Sainsbury's, the minister can relax. The system just runs itself. If the Dutch have proved that you don't need to have the government running hospitals, why would politicians want that responsibility? The role of markets in allocating society's resources dates back to at least 3000 BC. But according to Goodman, humans' innate suspicion of markets is a much older trait.
There is a reason for it in evolutionary psychology. So if you think about 50,000 years ago, how our ancestors lived, they didn't have an economic system the way we have one. They didn't have a political system like we have. And yet cooperation in a group was essential for their survival. So we're living in an economy where markets work and they work really well, but we're conditioned by our genes to not appreciate the value of markets.
Those claiming that healthcare is different to other markets often cite a 1963 paper by Nobel laureate Kenneth Arrow, which claims that the asymmetric information between doctor and patient limits the patient's ability to evaluate providers.
I'm going to hold up my iPhone here so you and everybody else can see it. So everything Kenneth Arrow said about healthcare is true about this iPhone. So if something goes wrong and I need it repaired, I can't imagine of the market being more asymmetric. I know a lot more about my healthcare than I know about that iPhone. We need agents. We need the doctor to be our agent. But when I get my iPhone repaired, I need the repair person to be my agent. And what's wrong with healthcare is that the incentives are wrong. In the market for iPhone production and repair, entrepreneurs know they can make millions of dollars by meeting our needs. And over in healthcare, we've so suppressed the market year after year, decade after decade, that entrepreneurs are not trying to meet our needs. They're trying to get more money out of third-party payers.
So what should Ireland's healthcare system look like?
Well, I'm not one of these guys who thinks we can go top down and reform the whole system overnight, because I realize how truly complex it is. And so I'm in favor of starting at the bottom and identifying perverse incentives and getting rid of them.
For those currently on medical cards, restoring patient charges of just €10 and giving them and their children each €120 of healthcare savings per year would allow them to see their GP monthly at no extra cost. But this skin in the game will change their behaviour, take pressure off the system, and challenge the dangerous article of faith of free healthcare. And over time, the closer the patient charges can be brought in line with real costs, the healthier the whole system will be. On the hospital side, given Ireland's lower population densities, public ownership will likely remain favoured, but the government can gradually grant autonomy to hospitals, requiring them to publish prices and break even, before gradually introducing patient charges. In truth, whether an entity is public, private, or non-profit is less important than whether it has to compete.
Well, I think the bottom line is that markets work. We need to try them in healthcare. We ought to liberate markets. We ought to liberate the patients, liberate the doctors, liberate the insurers. Don't try to do the whole system at once. Pick some of the worst cases where you have the biggest problems, liberate those parts first, and I think you're going to get really good results.
Ireland is one of the few countries that could hope to adopt some of the lessons from Singapore. Like the Swiss, most Irish people are used to paying to see their GP, giving the country the realistic prospect of not only getting to Dutch silver, but Swiss or Singaporean gold. What's more, like Singapore, Ireland has bumper corporation tax receipts, and the main thing keeping an Irish finance minister up at night is what to do with all the money. The sober advice is to establish a rainy day fund, but Ireland did that in 2001, and it lasted less than 10 years before it was raided after the crash. Moreover, in auction politics, a rainy day fund will never sound as good as make it rain. National reserves are of course needed, but these should be accompanied by individual reserves which can't be raided. This is not only good economics, since it causes little inflation, it is good politics, as helping voters build capital creates the political capital necessary to take a long-term view. As for the healthcare system, with Ireland's internationally renowned training schools and medical staff, the country has the personnel to become healthcare leaders, like it did in airlines and aircraft leasing, but it needs to create the conditions for the Michael O'Learys of healthcare to emerge. Any future IHS shouldn't be a service but a system, in which the power of markets can be brought to bear on our toughest problems and equity is achieved through generous cash transfers. The word provident means to be careful and wise in managing resources, especially for the future, and it carries biblical connotations, as does the word prodigal, meaning wastefully extravagant, which better describes Ireland's spending in recent years. If Ireland can come out from Britain's shadow, stop copying the NHS and foster a thriving healthcare market backed by large savings, the results will speak for themselves. Northerners will travel south and become familiarised with the system, which brings us back to a united Ireland. In the event of a yes vote, the problem will be that Northerners will have less savings if the UK continues on the prodigal path. The Irish state would then have no choice but to inject cash into Northern accounts, so it makes sense to start fattening the calf now through an Irish Provident Fund with a special Northern Reserve. And the larger this reserve becomes, the more attractive it will be to Northerners. Such long-term thinking will allow a provocative proposal to be put to Northerners in years to come. Will you throw your lot in with us, where your health and wealth will be better served? Will you leave those notoriously emotional English who still worship at the altar of free healthcare and join us, a sober people, who have long since left the old faith? For Irish politicians to walk the provident path will require courage and ambition. But as a wise Dutchman once said, "Let ambition fire thy mind."